A client's potassium level is 6.2 milliequivalent/L. Which finding would the nurse expect? A. Hyporeflexia. B. Muscle weakness and cardiac arrhythmia. C. Constipation. D. Bradycardia with no ECG change. Answer: B. Muscle weakness and cardiac arrhythmia. Rationale: a potassium level above 5.0 milliequivalent/L indicates hyperkalemia, which interferes with cardiac conduction and muscle function. The most concerning complication is ventricular dysrhythmia or cardiac arrest. ECG changes include peaked T waves and widened QRS complexes. Question 2. The nurse reviews a lab report showing a serum sodium of 128 milliequivalent/L. Which symptom should be closely monitored? A. Polyuria. B. Seizures and confusion. C. Dry mucous membranes. D. Increased thirst. Answer: B. Seizures and confusion. Rationale: a sodium level below 135 milliequivalent/L indicates hyponatremia, often causing cerebral edema. The brain is highly sensitive to sodium changes, leading to confusion, headache, and seizures due to water shifting into brain cells. Question 3. A client with chronic kidney disease has a BUN of 60 mg per deciliter and creatinine of 3.2 mg per deciliter. What does this indicate? A. Normal renal function. B. Dehydration only. C. Impaired kidney filtration. D. Low protein intake. Answer: C. Impaired kidney filtration. Rationale: both BUN and creatinine are elevated, confirming renal impairment. Creatinine is a more specific indicator of renal function because it is only excreted by the kidneys. In CKD, filtration declines, causing waste accumulation in the blood. Question 4. A patient's calcium level is 6.5 mg per deciliter. Which assessment finding requires priority intervention? A. Trousseau's or Chvostek's sign. B. Constipation. C. Polyuria. D. Flushing. Answer: A. Trousseau's or Chvostek's sign. Rationale: hypocalcemia, less than 8.5 mg per deciliter, increases neuromuscular excitability. Trousseau's sign, carpal spasm with BP cuff inflation, and Chvostek's sign, facial twitching when tapping facial nerve, are classic findings. Severe hypocalcemia can cause laryngeal spasm and seizures. Question 5. A diabetic client's fasting blood glucose is 280 mg per deciliter. What should the nurse anticipate? A. Insulin administration. B. Oral rehydration only. C. Administer glucagon. D. Restrict fluids. Answer: A. Insulin administration. Rationale: a fasting glucose greater than 126 mg per deciliter indicates hyperglycemia. Insulin helps lower blood glucose by promoting uptake into cells. Persistent hyperglycemia can lead to diabetic ketoacidosis, DKA, or hyperosmolar hyperglycemic state, HHS. Question 6. Which arterial blood gas, ABG, result suggests respiratory acidosis? A. pH 7.52, PaCO2 28 mm of mercury. B. pH 7.30, PaCO2 52 mm of mercury. C. pH 7.45, HCO3 20 milliequivalent/L. D. pH 7.35, PaCO2 35 mm of mercury. Answer: B. pH 7.30, PaCO2 52 mm of mercury. Rationale: respiratory acidosis occurs when CO2 is retained, PaCO2 greater than 45 mm of mercury, lowering blood pH, less than 7.35. Causes include hypoventilation, COPD, or airway obstruction. The kidneys compensate slowly by retaining bicarbonate. Question 7. A nurse notes a hemoglobin of 8.5 g/dl. Which symptom is most expected? A. Jaundice. B. Fatigue and pallor. C. Confusion. D. Polycythemia. Answer: B. Fatigue and pallor. Rationale: low hemoglobin indicates anemia, reducing oxygen carrying capacity. The body compensates with increased heart rate and respiration. Symptoms include pallor, weakness, and shortness of breath. Question 8. Which lab result requires the nurse to notify the provider immediately? A. Platelet count 80,000/mm superscript 3. B. Hematocrit 40%. C. Sodium 138 milliequivalent/L. D. Potassium 4.2 milliequivalent/L. Answer: A. Platelet count 80,000/mm superscript 3. Rationale: a platelet count 150,000/mm superscript 3 is thrombocytopenia, which increases the risk of bleeding. Critical levels, less than 50,000, can cause spontaneous bleeding and require careful monitoring or platelet transfusion. Question 9. A client on warfarin has an INR of 4.8. What should the nurse do first? A. Give the next warfarin dose. B. Administer vitamin K. C. Encourage fluids. D. Continue as normal. Answer: B. Administer vitamin K. Rationale: the therapeutic INR range for anticoagulation is 2 to 3. An INR greater than 4.5 increases bleeding risk. Vitamin K reverses warfarin's effects and should be administered as prescribed. Question 10. A client's magnesium level is 1 mg per deciliter. Which finding is expected? A. Hypotension. B. Tetany and hyperreflexia. C. Drowsiness. D. Bradycardia. Answer: B. Tetany and hyperreflexia. Rationale: hypomagnesemia, less than 1.5 mg per deciliter, causes increased neuromuscular irritability, tremors, and seizures. Magnesium stabilizes nerve membranes, so deficiency leads to overactive reflexes and possible arrhythmias. Question 11. A client's arterial blood gas shows pH 7.32, PaCO2 28 mm of mercury, HCO3 14 milliequivalent/L. What is the primary acid-base disturbance? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis with metabolic compensation. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: low pH, less than 7.35, and low HCO3 indicate metabolic acidosis. The PaCO2 is low, 28, reflecting respiratory compensation via hyperventilation to blow off CO2. Respiratory acidosis would have elevated PaCO2, alkalosis would have high pH. Question 12. A client's troponin I increases from 0.03 to 3.8 nanograms per milliliter. The nurse should: A. Document and continue routine care. B. Recognize myocardial injury and notify provider immediately. C. Start antibiotics. D. Give aspirin PRN only. Answer: B. Recognize myocardial injury and notify provider immediately. Rationale: troponin I is highly cardiac specific. A jump from normal to markedly elevated indicates myocardial injury or MI. This is urgent, requires telemetry, cardiac interventions, and provider notification. Antibiotics are not indicated solely for elevated troponin. Question 13. A client's BNP is 1,200 pg/ml. This lab most strongly suggests: A. Heart failure with volume overload. B. Liver failure. C. Dehydration. D. Normal aging. Answer: A. Heart failure with volume overload. Rationale: BNP is released from ventricles in response to stretch. Very high levels correlate with congestive heart failure and fluid overload. It's not specific for liver disease or dehydration and is typically higher than expected for normal aging. Question 14. A patient has serum creatinine 4.5 mg per deciliter, baseline 0.9. Best interpretation? A. Acute kidney injury or marked decline in renal function. B. Normal variation. C. Liver disease. D. Hyperthyroidism. Answer: A. Acute kidney injury or marked decline in renal function. Rationale: a sharp rise in creatinine versus baseline indicates reduced GFR and likely AKI or worsening CKD. Creatinine is a renal function marker. It is not an indicator of liver or thyroid disease. Question 15. A client's platelet count is 25,000/mm superscript 3. Which action is priority? A. Encourage ambulation to reduce clots. B. Implement bleeding precautions and notify provider. C. Give aspirin for pain relief. D. Start high-intensity exercise program. Answer: B. Implement bleeding precautions and notify provider. Rationale: platelets less than 50,000 increase bleeding risk. 20 to 30,000 poses high spontaneous bleeding risk. Priority is bleeding precautions, no IM injections, no NSAID/aspirin, soft toothbrush, and provider notification. Ambulation/exercise increases fall/bleed risk. Question 16. A client's PT/INR for warfarin therapy is 1.2 Indian rupees. Which action is indicated? A. Continue current dosing, if target 2 to 3, and monitor. B. Give vitamin K immediately. C. Hold all food intake. D. Start heparin infusion. Answer. A. Continue current dosing, if target 2 to 3, and monitor. Rationale. An INR of 1.2 is near normal and subtherapeutic if the target is 2 to 3. Action depends on indication. Often you continue and adjust under provider guidance. Vitamin K is for supertherapeutic INR/bleeding. Starting heparin isn't indicated without provider order. Question 17. Which urinalysis finding best supports a UTI? A. Positive leukocyte esterase and positive nitrites with many WBCs. B. Urine pH 7.0 only. C. Specific gravity 1.005 only. D. Mild glucosuria only. Answer. A. Positive leukocyte esterase and positive nitrites with many WBCs. Rationale. Leukocyte esterase indicates pyuria, nitrites indicate bacteria that reduce nitrates. Together with many WBCs, they strongly suggest bacterial UTI. Specific gravity and glucosuria are unrelated to infection diagnosis. Question 18. A client's serum sodium is 152 milliequivalent/L. Which clinical sign is most likely? A. Thirst, confusion, possible seizures, signs of hypernatremia. B. Bradycardia only. C. Peripheral edema only. D. Polyuria without thirst. Answer. A. Thirst, confusion, possible seizures, signs of hypernatremia. Rationale. Hypernatremia, greater than 145, reflects water deficit or sodium gain, causing cellular dehydration especially in the brain, leading to thirst, altered mental status, and potentially seizures. Peripheral edema is more associated with hypervolemia but not specific. Question 19. A client's amylase/lipase levels are markedly elevated. This points to A. Acute pancreatitis, lipase more specific. B. Myocardial infarction only. C. Pulmonary embolism only. D. Iron deficiency anemia only. Answer. A. Acute pancreatitis, lipase more specific. Rationale. Elevated amylase and particularly lipase suggest pancreatic inflammation. Lipase remains elevated longer and is more specific. Other conditions are not primarily indicated by these enzymes. Question 20. A patient has prolonged APTT while on heparin therapy. What is the nurse's best initial action? A. Hold heparin and notify provider if APTT is above therapeutic range. B. Increase the heparin dose. C. Administer vitamin K. D. Encourage ambulation. Answer. A. Hold heparin and notify provider if APTT is above therapeutic range. Rationale. Heparin dosing is titrated to a therapeutic APTT, usually 1.5-2.5 times control. If APTT is supertherapeutic, hold or reduce infusion and notify provider. Vitamin K reverses warfarin, not heparin. Question 21. A newborn has total bilirubin 20 mg per deciliter at 72 hours old. The nurse recognizes a risk for severe hyperbilirubinemia, evaluate for phototherapy/exchange transfusion. B. Normal physiologic jaundice always harmless. C. Diagnostic for hepatitis only. D. Indicator of hypoglycemia. Answer. A. Risk for severe hyperbilirubinemia, evaluate for phototherapy/exchange transfusion. Rationale. Bilirubin levels must be interpreted against age and hours and risk factors. 20 mg per deciliter at 72 hours is high and can risk kernicterus. This warrants prompt evaluation and likely treatment. Question 22. A client's anion gap is elevated at 20 milliequivalent/L. Which condition is consistent with this? A. Diabetic ketoacidosis or lactic acidosis, increased anion gap metabolic acidosis. B. Hyperventilation only. C. Dehydration only. D. Hyperkalemia only. Answer. A. Diabetic ketoacidosis or lactic acidosis, increased anion gap metabolic acidosis. Rationale. An increased anion gap indicates accumulation of unmeasured anions, classically DKA, lactic acidosis, renal failure, or toxic ingestions. Hyperventilation produces respiratory alkalosis and doesn't raise the anion gap. Question 23. A client's WBC count is 22,000/mm superscript 3 with a left shift. What does this pattern typically indicate? A. Acute bacterial infection or inflammatory response. B. Bone marrow suppression. C. Chronic anemia only. D. Normal variant. Answer: A. Acute bacterial infection or inflammatory response. Rationale: leukocytosis with bands, left shift, signals acute bacterial infection or significant inflammation. Bone marrow suppression causes leukopenia, not leukocytosis. Question 24. A patient's serum potassium is 2.7 milliequivalent/L. Which ECG change is most likely? A. U waves and flattened T waves. B. Peaked T waves and widened QRS. C. Normal ECG always. D. Short PR interval only. Answer: A. U waves and flattened T waves. Rationale: hypokalemia causes characteristic ECG changes, U waves, flattened or inverted T waves, and predisposition to ventricular arrhythmias. Peaked T waves are seen with hyperkalemia. Question 25. A client's magnesium is 3.5 milligrams per deciliter, elevated. Which finding is expected? A. Decreased deep tendon reflexes and hypotension, signs of hypermagnesemia. B. Hyperreflexia and seizures. C. Hypoglycemia only. D. Muscle spasms only. Answer: A. Decreased deep tendon reflexes and hypotension, signs of hypermagnesemia. Rationale: hypermagnesemia depresses neuromuscular transmission, diminished reflexes, hypotension, bradycardia, and, at severe levels, respiratory depression. Hyperreflexia and seizures occur with hypomagnesemia. Question 26. A patient's serum phosphorus is 1.8 milligrams per deciliter, low. Which clinical problem can result? A. Muscle weakness, respiratory failure risk, and hemolysis. B. Hypercalcemia only. C. Hypertension only. D. Increased bone density only. Answer: A. Muscle weakness, respiratory failure risk, and hemolysis. Rationale: hypophosphatemia can cause muscle weakness, including respiratory muscles, rhabdomyolysis/hemolysis, and impaired myocardial contractility. It's clinically significant in critically ill or refeeding patients. Question 27. A client's serum albumin is 2.0 g/dl. The nurse anticipates: A. Peripheral edema due to decreased oncotic pressure. B. Polycythemia only. C. Hypernatremia only. D. Increased intravascular oncotic pressure. Answer: A. Peripheral edema due to decreased oncotic pressure. Rationale: low albumin decreases plasma oncotic pressure, causing fluid shift into interstitial spaces, edema, and possible ascites. It does not cause polycythemia or increased oncotic pressure. Question 28. A patient's BNP is mildly elevated but the client has renal failure. How should the nurse interpret BNP? A. BNP can be elevated in renal failure. Interpret cautiously in context of volume status and symptoms. B. BNP is only specific to heart failure and not affected by renal function. C. Elevated BNP excludes renal causes of symptoms. D. BNP is irrelevant clinically. Answer: A. BNP can be elevated in renal failure. Interpret cautiously in context of volume status and symptoms. Rationale: BNP is influenced by renal clearance, levels may be higher in renal impairment. Use clinical correlation, edema, JVD, imaging, rather than interpreting BNP in isolation. Question 29. Which lab pattern is expected in SIADH? A. Hyponatremia, low serum osmolality, and concentrated urine, high urine osmolality. B. Hypernatremia and dilute urine. C. Hypokalemia only. D. Elevated BUN only. Answer: A. Hyponatremia, low serum osmolality, and concentrated urine, high urine osmolality. Rationale: SIAD causes water retention from excess ADH, dilutional hyponatremia with inappropriately concentrated urine despite low serum osmolality. DI produces dilute urine and hypernatremia. Question 31. Which lab abnormality increases the risk for digoxin toxicity? A. Hypokalemia. B. Hypernatremia only. C. Normal potassium only. D. Hypermagnesemia only. Answer: A. Hypokalemia. Rationale: low potassium enhances digoxin binding to cardiac NA/KAT passe, increasing drug effect and risk of toxicity, arrhythmias. Maintain normal potassium to reduce digoxin toxicity risk. Question 32. A client's CRP and ESR are elevated. What does this indicate? A. Presence of inflammation or infection, nonspecific markers. B. Specific diagnosis of lupus only. C. No inflammation. D. Low chance of infection. Answer: A. Presence of inflammation or infection, nonspecific markers. Rationale: CRP and ESR rise with inflammation, infection, autoimmune disease, tissue injury. They're nonspecific and don't establish a precise diagnosis but aid clinical assessment. Question 33. A patient's ABG, pH 7.48, PaCO2 32 mm of mercury, HCO3 24 milliequivalent/L. Interpretation: A. Respiratory alkalosis, acute. B. Metabolic acidosis. C. Metabolic alkalosis. D. Normal ABG. Answer: A. Respiratory alkalosis, acute. Rationale: elevated pH with low PaCO2 indicates respiratory alkalosis due to hyperventilation. HCO3 is normal, no metabolic compensation yet, suggesting acute process. Question 34. A client's CKMB is elevated but troponin is normal. What is the likely interpretation? A. Recent or small myocardial injury, troponin is more specific and may rise later, correlate clinically. B. CKMB indicates liver failure only. C. Troponin is irrelevant. D. CKMB elevation is always false. Answer: A. Recent or small myocardial injury, troponin is more specific and may rise later, correlate clinically. Rationale: CKMB can rise with myocardial injury but is less specific than troponin. Timing matters, troponin may rise later. Clinical context and serial measurements are needed. Question 35. A client's fasting lipid profile shows LDL 190 mg per deciliter, HDL 30 mg per deciliter, triglycerides 260 mg per deciliter. Best action? A. Counsel on lifestyle changes and consider statin therapy, high cardiovascular risk. B. Reassure that no action is needed. C. Start antibiotics. D. Recommend high saturated fat diet. Answer: A. Counsel on lifestyle changes and consider statin therapy, high cardiovascular risk. Rationale: LDL greater than or equal to 190 is very high, combined with low HDL and high TG. This confers high atherosclerotic risk. Lifestyle modification and likely pharmacotherapy, statins, are indicated after assessment. Question 36. Which lab set indicates disseminated intravascular coagulation, DIC? A. Prolonged PT/INR and APTT, low platelets, elevated D-dimer, low fibrinogen. B. Normal coagulation with high platelets. C. Shortened PT and APTT. D. Elevated hemoglobin only. Answer: A. Prolonged PT/INR and APTT, low platelets, elevated D-dimer, low fibrinogen. Rationale: DIC is a consumptive coagulopathy, prolonged clotting times, thrombocytopenia, elevated fibrin degradation products, and low fibrinogen, leading to both thrombosis and bleeding. Question 37. A patient receiving multiple units of stored blood can develop hypocalcemia due to: A. Citrate in transfused blood binding ionized calcium. B. Excess vitamin K only. C. Hypernatremia only. D. Direct magnesium depletion. Answer: A. Citrate in transfused blood binding ionized calcium. Rationale: stored blood contains citrate anticoagulant, which can bind ionized calcium during massive transfusion, causing hypocalcemia. Monitor CA and replace if symptomatic. Question 38. Which lab finding supports diabetic ketoacidosis, DKA? A. Hyperglycemia, metabolic acidosis, low HCO3, elevated serum/urine ketones, high anion gap. B. Hypoglycemia only. C. Low ketones only. D. Normal ABG. Answer: A. Hyperglycemia, metabolic acidosis, low HCO3, elevated serum/urine ketones, high anion gap. Rationale: DKA is defined by hyperglycemia, ketosis, and metabolic acidosis with an increased anion gap. This triad distinguishes it from other hyperglycemic states. Question 39. A patient's ammonia level is elevated at 120 moles/L with confusion. This most likely indicates: A. Hepatic encephalopathy from liver dysfunction. B. Myocardial infarction only. C. Pneumonia only. D. Normal elderly change. Answer: A. Hepatic encephalopathy from liver dysfunction. Rationale: high ammonia results from impaired hepatic metabolism and is associated with hepatic encephalopathy, confusion, asterixis, and altered consciousness. It is not a marker for MI or pneumonia. Question 40. A client on ACE inhibitor therapy should have which labs monitored? A. Serum creatinine and potassium, risks, increased creatinine and hyperkalemia. B. ALT only. C. CBC only. D. Glucose only. Answer: A. Serum creatinine and potassium, risks, increased creatinine and hyperkalemia. Rationale: ACE inhibitors can increase serum creatinine, ESP with renal artery stenosis, and cause hyperkalemia by reducing aldosterone. Monitor both after initiation/dose changes. Question 41. A patient's urine-specific gravity is 1.035. Which interpretation is correct? A. Concentrated urine, possible dehydration or prerenal azotemia. B. Indication of diabetes insipidus. C. Normal dilute urine only. D. Sign of hyponatremia only. Answer: A. Concentrated urine, possible dehydration or prerenal azotemia. Rationale: high specific gravity, greater than 1.030, indicates concentrated urine, often from fluid deficit or kidneys conserving water, prerenal. Diabetes insipidus causes low specific gravity, dilute urine. Question 42. A client CRRT, continuous renal replacement therapy, is running. Which labs should be monitored frequently? A. Electrolytes, K, Na, acid-base status, HCO3, and creatinine/urea. B. Annual lipid panel only. C. TSH only monthly. D. PSA only yearly. Answer: A. Electrolytes, K, Na, acid-base status, HCO3, and creatinine/urea. Rationale: CRRT clears solutes and affects electrolytes and acid-base balance, so frequent monitoring guides replacement and adjustments. Other labs listed are not immediate CRRT concerns. Question 43. A client's fractional excretion of sodium, FeNA, is 0.5%. This finding suggests A. Prerenal azotemia, kidneys conserving sodium. B. Intrinsic renal failure, ATN. C. Postrenal obstruction only. D. Normal kidney function only. Answer: A. Prerenal azotemia, kidneys conserving sodium. Rationale: FeNA less than 1% suggests prerenal causes, decreased perfusion, where kidneys conserve sodium. FeNA greater than 2% points to intrinsic renal tubular injury, ATN. Question 44. A patient has urine osmolality low with hypernatremia. Which condition is most likely? A. Diabetes insipidus, inability to concentrate urine. B. SIAD. C. Hypothyroidism only. D. Dehydration with concentrated urine. Answer: A. Diabetes insipidus, inability to concentrate urine. Rationale: DI produces dilute urine, low urine osmolality, despite hypernatremia or hyperosmolality due to lack of ADH effect. SIAD causes concentrated urine and hyponatremia. Question 45. A patient receiving TPN develops persistent hyperglycemia. What is the most appropriate monitoring intervention? A. Frequent bedside glucose checks and adjust insulin therapy as needed. B. Daily lipid profile only. C. TSH every week. D. No monitoring is required. Answer: A. Frequent bedside glucose checks and adjust insulin therapy as needed. Rationale: TPN contains high dextrose and can cause hyperglycemia. Monitor glucose frequently, Q4, 6H or more often, and titrate insulin to maintain target glucose levels. Question 46. A child presents with suspected Rye syndrome. Which labs would support that diagnosis? A. Markedly elevated AST/ALT and high ammonia, hepatic dysfunction. B. Low sodium only. C. Elevated troponin only. D. Elevated creatinine only. Answer: A. Markedly elevated AST/ALT and high ammonia, hepatic dysfunction. Rationale: Rye syndrome causes acute liver failure, elevated transaminases, and hyperammonemia leading to encephalopathy. The other labs listed are not diagnostic for Rye syndrome. Question 47. A patient's procalcitonin is markedly elevated. This is most suggestive of A. Bacterial sepsis or systemic bacterial infection. B. Viral infection only. C. Fungal infection only. D. No infection at all. Answer: A. Bacterial sepsis or systemic bacterial infection. Rationale: procalcitonin rises in systemic bacterial infections and sepsis, and is sometimes used to guide antibiotic decisions. It's generally low in viral infections. Question 48. Which lab abnormality is classic in Addison disease, primary adrenal insufficiency? A. Hyponatremia and hyperkalemia with low cortisol. B. Hypernatremia and hypokalemia only. C. Elevated TSH only. D. High hemoglobin only. Answer: A. Hyponatremia and hyperkalemia with low cortisol. Rationale: primary adrenal failure leads to low aldosterone sodium loss, hyponatremia, and potassium retention, hyperkalemia. Cortisol deficiency causes fatigue and hypotension. Question 49. A client with tumor lysis syndrome is at highest risk for which electrolyte abnormality? Answer: A. Hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. Rationale: rapid tumor cell lysis releases intercellular contents hyperkalemia, increased phosphate, which binds calcium causing hypocalcemia, and elevated uric acid, risking renal failure and arrhythmias. Question 50. A patient's ESR and CRP are rising after starting therapy for inflammatory disease. Which is the most accurate nurse interpretation? A. Inflammatory activity may still be present or therapy insufficient. Correlate clinically and notify provider. B. Therapy is clearly effective, no concern. C. Lab error always. D. No correlation with clinical status. Answer: A. Inflammatory activity may still be present or therapy insufficient. Correlate clinically and notify provider. Rationale: rising inflammatory markers suggest ongoing inflammation or inadequate therapy. Always interpret labs together with clinical findings, symptoms, exam, before concluding effectiveness.